Good afternoon, everyone. Thank you, Nancy, for that great introduction. I didn't know that was coming. And I also know that I want to be liked, so I'll try my best to let you go early. I'm absolutely honored to be here today to talk more about the Healthy Teeth, Healthy Baby initiative, which is Minnesota's legislative commitment to prevent early dental disease. Nancy, can you help me? Okay, thank you. So today I have my supervisor from Minnesota Department of Health. I also have my colleagues from both Department of Health, Department of Human Services. We have Dr. Peterson, the founder of the Healthy Teeth, Healthy Baby, or Early Dental Disease Prevention Initiative. I've been meeting great advisors today, partners. So it's just amazing to be part of this presentation. So the way I've organized today's presentation is that I'm just up here in the podium, but it's really going to be a conversation. My role is just going to be more of that of a facilitator. And I think my colleagues and my supervisor would try to comment on things that I'm speaking, and I would also turn to them to answer any of the questions that you may have. But I think you've seen me presenting on EDDPI a few times now, at least some of you. Most of the times I talk about passion, I talk about it's so important to educate families, but I think because we talk about how every connection count or make every connection count, I think it is the time to look at that collaboration and partnership, and maybe it's the time to look at the Healthy Teeth, Healthy Baby initiative through the lens of health equity, because I think we've not done that. It's very important to talk about health literacy and why Healthy Teeth, Healthy Baby goes beyond just oral health care, access issues, and just being passionate about oral health, correct? So I think that's what the objective is. I think by the end of the presentation, again, this is my personal hope, that we would be able to view Healthy Teeth, Healthy Baby through the lens of health equity. We would also be able to look at some of the data that we have analyzed using CMS report and some data that we have from DHS, because we totally understand that we have limited data when it comes to 0 to 5 population. We would also try to talk about Early Dental Disease Prevention Initiative, or Healthy Teeth, Healthy Baby, which is the community name for us. At the programmatic level, definitely we are going to recognize all our partners, and we will celebrate the success, because I think that's what it is all about. And we'll talk about child and teen checkup and how we have integrated, or let's say how we've become more innovative with that integration. And I think that again goes back and aligns well with how we can make all those connections count. Towards the end, I'll talk about great educational tools that our advisory committees have supported us to develop, and that is something that we were required to do as part of the bill. So we would love to share that resources with you, because again, we do not want to reinvent the wheel. Let's share the resources. And probably let's save some time so that you would advise us as MDH for our next steps, because it doesn't have to be what we think that works for all the communities, because we truly believe that the communities we work with are so unique, with their unique cultural practices, with their social norms, with the kind of resources they have. So I think we need to hear from you as to how we should go more with EDDPI. Can I have the next slide, please? Okay, next slide, please. So we all know that Minnesota continues to be one of the healthiest nations one of the healthiest states in the nation. However, we also know that from, I think, the ranking of 1, we are slowly declining to, I think, the current ranking of 6. The reason why we see this decline is really that disparity, that significant disparity that we are seeing between the health outcomes of people from different ethnic cohorts, from different geographical locations, or even with their incomes. The interesting part about, when you read these reports, the interesting finding is that these disparities are definitely not the outcome of, poor medical care. It's not because we don't have access to oral health. It is driven by the socioeconomic factors that we come across in our daily lives. Many of you may already know that I'm from Nepal, as Nancy mentioned. I'm also a foreign trained dentist, so I've spent significant time serving people back home where I used to work with children. I used to go to like villages with my students, medical students, because we don't have that many dental clinics. So there were times when, like families will bring their little kiddos to us, and they would ask us to remove the first permanent molar, even though, it could be fixed with a certain kind of filling or restoration, because that is only the time they have access to dental care, correct? So, and then, so those were like ethical issues that I faced in my life, where I also saw kids die of preventable diseases such as diarrhea and cholera. So my country is still in that situation where we are educating people on the importance of hand washing. So for me to expect that just because I say it, just because I'm passionate about it, and because I have access to soft toothbrush, like soft bristle toothbrush or fluoridated toothpaste, it's not possible for our families to be able to afford that, correct? And even when I moved here and I saw that there were so many clinics all around, but then again, the utilization was the access or the utilization was the issue. I volunteered with so many nonprofits that really made me understand how our families are struggling with Maslow's hierarchy of needs. We cannot assume that a family would show up at the dental appointment assuming that they have cars or they know how to drive, right? We need to ask them, like, do you need like bus pass by any chance? Sometimes like gift cards would not work as an incentive because there are so many priorities that our families are dealing with. Life changes, right? Divorces, there's so many things. It's just hard for parents to keep track of all these things, even though they want to. So behavior change, I think it's a process, and it cannot be achieved within short period of time. That is the reason why, as MDH, we really focus on triple aim of health equity, where we are really trying to expand the understanding of what is that thing that really creates health. Is it just the access issue? Can it be really like prevention and education, where we are first preventing the onset of early dental disease? Or is it really that our families have lost hope in the system, that they do not want to even, like take advantage of the free services that we want to give to them? What it is, right? The other thing is that we really need to look at all the policies through the health perspective. That means we need to implement health in all policies. One good example would be when I think legislators are looking at the drinking water policy, they also think of water fluoridation policy for all the counties, correct? Also making sure that we are strengthening the capacity of our community. I totally understand how we become donor-guided at times. It's very challenging when you're already passionate about bringing about those behavior change. But when we are struggling with the same resources, the grants are so limited that you cannot just move beyond that time. So if the grant ends, our project ends. So what is the community going to do? It's not even their fault. So we need to make sure that we are giving them that skill so that even after we step back, they are empowered. They have the skills to take charge of their health and make that informed decision. And at the core of all these things should really be equity. We should look at all the resources that we have and use them more efficiently so that we have better oral health for all the population. Next slide, please. Next slide. So we were also able to look at some data from CMS, and this map talks about geographic variation in the use of preventive dental services, and it really is clear that Minnesota is in the lowest quarter of percentages of Medicaid-eligible children in the US who receive preventive services, even though we all know that preventive services is one way to improve the oral health of the population. So that is the reason why I think many of you are aware that CMS sent us a letter reminding us that we've not been able to provide the basic services that we should have guaranteed all our children, correct? Next slide, please. We are also not doing well with the dental services, but I think because we are MDH, we are more focused on the dental public health aspect, so I think we still want to focus on prevention and education, but even when it comes to dental services, I think we are still in the lowest quarter of percentages of Medicaid-eligible children in the US who receive these dental services. So we are probably, like doing very poor when it comes to the national comparison. Next slide, please. So this is another interesting data that we were able to analyze from CMS, and some of this data came from DHS. We found that less than half, That's like less than 50% of Minnesota children aged 0 to 5 years enrolled in Medicaid received their recommended annual dental visit. So if our kids are not getting these annual dental visits, then it's very hard for providers to, like really educate the parents on the importance of oral health. And again, there would be less focus on prevention. Next slide, please. We were also able to find that 1 in 5 Minnesota children age 0 to 5 enrolled in Medicaid received their recommended annual preventive dental visit. So even though dental visit and preventive dental visits kind of sound similar, preventive dental visit really emphasizes on fluoride varnish application, education, and those sort of preventive services that have specific coding for the billing purpose. Next slide, please. Less than 15% of Minnesota children aged 0 to 5 years enrolled in Medicaid received an oral health service from a non-dental provider. It's just amazing to see how Dakota County presented on, like the efforts that public health nurses were doing. And time and again, we have really talked about, even with Nancy and the coalition, how we should really make every connection count, because we really see non-dental providers such as public health nurses, community health workers, and other non-dental professionals as dental workforce, but they are emerging dental workforce. I don't know how the concept sounds to you, but I really believe that they are the ones who are really improving the oral health preventive services at the community level. So it's and non-dental providers such as child and teen checkup providers or public health nurses, they are in unique position to provide preventive services and also prevent early dental disease. However, we found that less than 15% of Minnesota children enrolled in Medicaid received oral health services from non-dental provider, which means really fluoride varnish application, right? So if you want to look at these categories, so less than 1 years of age, 2.3%, probably around 21% of eligible children between age 1 to 2 received fluoride varnish application. 3 to 5 age category, 14.3%. Next slide, please. Another interesting thing that we analyzed from the data from DHS is that out of 5,734 child and teen checkup enrolled child and teen checkup providers, only 23% of them were filing the claims for fluoride varnish application. Again, there are two things to look at this data. I'm a passionate dental public health professional, so for me, it's like, okay, at least 23% of our kids are getting fluoride varnish application, right? So it's a big thing, right? But then if you really look at, can you go to the next slide? But if you really look at, let's say, our surveillance portal, Minnesota Oral Health Statistics System, we go by the name MINOS. It's really like a data made easy portal. We don't have any data for 0 to 3 or 0 to 5 population. Because if we totally understand and acknowledge all our partners who are providing fluoride varnish application in a community setting. However, if there is no claim that has been, filed, then when CMS is sending us the letter, whether it's to MDH as dental public health arm or to DHS as the dental public services delivery arm, we are state of Minnesota, correct? So we do not have any evidence to tell them that, no, our partners are so passionate, they are doing amazing work. There is no evidence for us to show them that despite of us doing great work at the community level, we just have no answer that we can probably give to CMS, and that has been a big challenge. The other big challenge with this data piece is that if there is no claim data, then probably nothing was done, correct? Even though we totally understand that there are good things happening. We know of many nonprofits who've been providing free services in the community. We love them because, we are so happy that at least wherever there are access issues, our kids are getting services. But then you have to build the kids. That's the federal policy. So we as MDH are, sometimes caught up in between these policies, and dental public health and passion is somewhere there. Sometimes we just get so, it's really challenging. So I think this is the time that we can probably talk more about these challenges where you want to support them, you want to improve the preventive services, but sometimes you just cannot, right? So we would really encourage all of you to, voluntarily share your data. Again, we do not have any data sharing statute, so we wouldn't be able to tell you that, oh, you have to, give us the data. It's all voluntary. There are other states who've had this model where all the stakeholders are sharing their data voluntarily, and that's how you can really understand what's happening across the state of Minnesota. That also really helps us, like reach out to different partners when someone reaches out to us and asks us, like, what is happening in Dakota County, or what is happening in, like in some other region. We can at least tell them that these resources are there and you wouldn't have to duplicate the services. So next slide, please. So we all know that, I think most of us agree that the basic problem is really like the access problem. We have like so many counties that are designated as dental HIPSA, so probably health professional shortage area. But one of my colleagues shared that even to be identified or labeled as dental professional, health professional shortage area, the counties would have to apply. So maybe some counties you see that there is no access, but maybe the county has not applied, so maybe that's the reason why you do not have that label. I don't think it's necessarily a good or a bad label, because I think it also improves your chances to get more resources from the state level. So I think I try to look at it in a positive way, where we can direct more services to your county, because now we know that these are the designated areas where we should be really focusing on. So I do not think it's like necessarily good or a bad thing. We have so many reasons why we have access issues. For example, recently we were with different programs who really brought up a good point. Dental hygienists can perform certain risk assessment, but there are challenges with the billing and reimbursement thing, so we need to talk more about those things. Next slide, please. So I think because we kind of knew that there were all these things going on, we were not doing good with our preventive services or providing dental services. Again, there were so many access issues, and these things cannot be fixed overnight. So I think in 2015, Dr. Peterson, I would like to thank you one more time. She advocated for the bill, and I think in 2015 we had the bill. I think the bill was passed in 2015. So I think the credit goes to Dr. Peterson, and then MDH was charged with implementation of the project. So that is why the official name of our project is Early Dental Disease Prevention Initiative. EDDPI sounds good to us, right? Our communities know us by the name of Healthy Teeth, Healthy Baby, because that was the name suggested by different focus group discussion. So we are basically a community-based initiative based on the notion that prevention of early dental disease starts prenatally, and it's most effective in the first 3 years of life. Even though we work with all the population, we are geared more towards communities of colors, recent immigrants, and underserved population. We have a model, so I think I was hired at that time as EDDPI coordinator to give more structure to the bill. So I worked with our advisory groups. We had different work groups. I worked with my supervisor at that time. I reached out to other stakeholders, and we came up with prenatal to 3 model, because we truly believe that prevention of early dental disease starts prenatally. So what we did is, if you can see the prenatal to 3 model on the slide, we have different components. For example, we have prenatal oral health promotion, then we have anticipatory guidance, then we have home care instruction, which is really like teaching oral hygiene skills to parents. We also have oral, like 5 key messages that we would want to promote, because it's so hard to even narrow down what is important to talk about. And then at the end, we have something like establishing a dental home for the kid. So these are the components of our project. These are different activities based on the clinical guidelines. We couldn't come up with things that we felt was correct, so we wanted to stay with the clinical guidelines. And then we have 5 building blocks of EDDPI. So these blocks have been pulled from the bill, literally from the bill. So the bill requires us to work with the communities. The bill requires us to develop educational materials. The bill requires us to come up with an incentive to motivate families so that they can take care of their baby's teeth. And the bill also requires us to identify distribution sites across the state of Minnesota and distribute those educational materials as well as those supplies or those incentives. I think we've been able to do that. So I think at the core of all these building blocks, we added medical dental integration, again, making all the connection count. Without medical dental integration, I think it's not possible for oral health community to talk about, like all those health improvement, because I think oral health is also part of the general health. So we really feel that medical dental integration is something that would hold all these blocks together. So at the end, we just want to make sure that we are handing over cavity-free kids to programs such as Head Start that already has such robust oral health system, so that at least we are not dealing with something like reduction in caries by 50% or 90%, something that we may not be able to do as just being the dental public health part of the system. So we want to prevent the onset of early dental disease. We want to make sure that there is less burden on the healthcare infrastructure. Again, Medicaid has been the most common payer of kids going to the ER for their like dental services. And eventually, we would want to decrease the impact of early dental disease on the state as a whole. Next slide, please. So these are some of the clinical pictures of early childhood caries. I think you've been seeing it in your clinical practice as well as in your communities. Next slide, please. And at this time, I think we really need to celebrate our success. We do not have any reporting mandate, but then we are still trying to come up with an evaluation. We've completed the first 2 years of our project, so we still want to make sure that the state of Minnesota has something to measure. So we would very soon come up with an evaluation of the program so that we can share that with you. But I truly feel that our success is the kind of collaboration we've been able to establish with all our amazing partners. I also feel that we've been able to bring together partners together. I really see that we all have come together as the state of Minnesota versus, oh, it's MDH and, oh, we are like a dental clinic or nonprofit. So I think that is our true success, I would say. And at this time, all of you who know about our initiative, who are our advisors, pilot sites, or advocates for EDDPI, would you please just stand up for like a couple of seconds so that we can recognize you? All the advocates of EDDPI, all those who've been involved with EDDPI. Okay. Thank you. That is our success, I think, even though we would come up with an evaluation plan. The other success is really that we've been able to provide a very small funding to 14 different sites across the state of Minnesota, making sure that even greater Minnesota sites were part of it. We were not able to reach out to each one of you. We're very sorry for that because we had like certain timeline. But then I think these 14 sites, what we are doing with them is instead of MDH telling them that, oh, it's a state-funded project, so all of you should be doing this thing because we want you to do certain things certain way, we are asking communities to teach us promising practices, what may work better for them. Because even though I was tasked with, like coming up with a model for EDDPI, I really feel that we are so unique, we are so diverse, and then you're like, each of us have our different strengths. The resources are different, the barriers are different, the strengths are different, so one model may not work for all of us, correct? So these 14 sites are really, really teaching us what we should be doing as a state of Minnesota to really tailor the Healthy Teeth, Healthy Baby initiative to meet the needs of their communities. And that is our success. Next slide, please. So I borrowed this slide from Faith Kidder, who has been an advocate for oral health. She's a child and teen checkup, child health consultant at MDH. So the reason why I wanted to talk about child and teen checkup quickly is that, again, medical dental integration is really important for us to make sure that our kids have better oral health. And child and teen checkup providers really have a unique opportunity to support us. Recently, what we did is, I think we were kind of innovative in our integration. So we ended up sharing a health educator from the Child and Teen Checkup program at MDH. So she's bringing in all the resources for us, like access to WIC, access to different kinds of maternal child health program. So Faith was she's still our go-to person, but just having a designated health educator really improves our capacity to also support our medical clinics to do more of fluoride varnish application. So child and teen checkup would really require all of the providers to make sure that teeth and mouth are part of their exam. Fluoride varnish application is now a requirement, and again, dental referral is also a requirement. And oral health risk assessment is a recommendation, but we are trying to make sure that that becomes like a requirement. Next slide, please. For those of you who are new to Child and Teen Checkup, they do have a periodicity schedule, and towards the bottom it talks about, like oral health screening. It talks about fluoride varnish application. So those dots really say that they are not recommendation, but they are absolutely requirement. So that's a great thing for us, and we just want to make sure that we are tapping into these resources. Next slide, please. Again, it just talks about, like how fluoride varnish application is a requirement, but oral health risk assessment is not, and how we should talk about fostering medical and dental care. Next slide, please. This is a schedule for dental providers. There are two different schedules when it comes to fluoride varnish application. So if child and teen checkup providers get reimbursed 4 times a year for fluoride varnish application, dental providers get it reimbursed for 2 times. And I think earlier there was really an access issue, so the state had to come up with an innovative way to improve the access. So I think that was the reason why this was done, I'm thinking, to make sure that, because kids are visiting their child and teen checkup provider more often and on a regular basis. So I think that was the reason why they ended up making sure that the reimbursement was up to 4 times a year. Next slide, please. So again, this is just a caries risk assessment tool. I'm sure many of you have used it. Every time you're doing fluoride varnish application, please make sure that you're also training your trainees on oral health risk assessment, because the oral health of mom is critically important, and we want to make sure that the risk is assessed well, and then there is a prompt referral. Next slide. Next slide. I think we can go to the next slide. Okay, so here are some resources for those of you who are trying to provide fluoride varnish application or are doing some trainings. Smiles for Life is a standardized curriculum that, for example, if I want to apply fluoride varnish, I would have to take that module. But again, we get calls, emails from different non-dental providers, public health nurses asking us to help them in person. Again, this is a standardized curriculum. We are not trying to replace it, but I really feel that sometimes it's the question of competency and comfort. How many of us who are non-dental provider are really comfortable, making sure that we are comfortable with the saliva? There are behavior management issues. There are lab-to-lab exams, and there are so many other things that, and then we have kids who have special needs. So there are lots of things that comes with fluoride varnish application. That's what I would want to emphasize on. That's why we feel oral health risk assessment is something that we should always accompany the fluoride varnish application, because it's not just applying fluoride varnish application. You need to make sure that there is prompt referral too. And then the educational part should always be there. So there were some questions around billing and coding. Please feel free to reach out to us or to Dr. Linda Mayten, who would redirect you to resources from DHS. Next slide, please. So this is just a picture of fluoride varnish application. It's relatively a very simple process. And I think there were questions around, for example, if CHW or a community health worker is doing the fluoride varnish application, there were questions around billing. So there has to be a medical director or a dental director who needs to sign the prescription so that at least it can be filed for the claims. Next slide, please. I think before I start the family education, these are just like pictures. I would again emphasize that if you feel at the community level that filing the claim is really a challenging process, I think Nancy would be in a very good position to lead this conversation around how we can understand your perspective around simplifying the administrative issues related to the Medicaid reimbursement. Maybe that's something we need to look at so that it's like a win-win situation for all of us. Some of the educational tools that we have is really, this is a goal-setting tool that we use from Bright Future. Very good tool to set those little goals with your families. Next slide, please. So this is something we created. We are very proud of our communication tools. Thank you to our advisory members and our work groups who tremendously worked on the 5 key messages. And that is how our poster looks like. We emphasize on talking to your dentist or doctor about caring your baby's teeth. That absolutely aligns with making all the connection count, right? It's not trying to devalue the role of a dentist. No, that was not the intention. We are trying to also emphasize the importance of non-dental provider who are really improving the access and providing those preventive care. So even though, these things are not clinically written, this is how it might work for us, right? Because maybe this is the way we can improve the access. So that's why we really wanted to make sure that we were valuing the role of non-dental providers too. Next slide, please. So this is the lift the lip. It's a mirror cling. We just want to make sure that we are teaching parents how to lift the lip so that at least they are also identifying the early dental disease. Sometimes we just educate people, but we don't teach them skills, so they don't know what to do. So we need to teach them some actions. That's what we are trying to do. Next slide, please. Fluoride varnish card. And thank you to Rice Regional dental clinic for coming up with this concept, and it was their idea to have fluoride varnish card, and we got the approval from them to have this at the state level. So for now, we do have fluoride varnish card, just to make sure that we are tracking the referral with the change in fluoride varnish application policy. We are already hearing questions around how we can track the fluoride varnish application for the purpose of billing, so this might be a great tool. But I think in the future, we are thinking of establishing a fluoride varnish registry, but again, we need to talk more about that. Next slide, please. This is a great video from University of Maryland. We really have good relationship with them. But what we did for the state of Minnesota is that we translated this video in 5 languages, Somali, Karen, Hmong, and Spanish. This is a great tool for, like your training of trainers, even for families. So we would be, I think all the subtitling, everything is probably done, and we would be able to have this on our website as soon as possible. Next slide, please. So we also reached out to NIH, the National Institute of Health, and they've given us the permission to use their materials. They would love us to use their materials. So we have narrowed down some of the videos from their website. We also have prenatal oral health education that we adopted from American Dental Association. And one more time, I would want to emphasize that Minnesota Oral Health Coalition has already developed a video on fluoride varnish application. So please do not duplicate the services. Reach out to Nancy. She's been very collaborative, and we have the permission to use it for EDDPI, and it's the resource for everyone, so we wouldn't have to create another video. I'm just mentioning this point here because I get many emails asking for support and some resources around fluoride varnish application. It is already there. We are trying to have it on MDH webpage too, so that it's more accessible. Next slide, please. So again, I started with the equity, so I just wanted to make sure that I was ending it at the same note. So I think equality would be, like you just get the shoes for everyone. But equity is really like getting the right shoes that fits everyone, correct? So I think with EDDPI, what makes us absolutely different is that we're not trying to force any model on any counties. Rather, we are asking them to tell us what works best for them, and we would want to collaborate with each county. We would want to be more at the regional level, and we would want to make sure that we are supporting you with all the resources that you need. Next slide, please. So next steps, I think I'll just take 5 minutes to ask you for your feedback or comments. I don't know how I'm doing with my time. I don't want to. Okay, so I think we should still have like 5 minutes for your opinion. These are just our thoughts. We can go on and on and on with that, but we just want to know what you think we should do, so that, because it's not only MDH's initiative, right? It's all our projects. So is there anything that you would want to share, talk about, or any suggestion for us, or any success stories that we get to hear today? Nancy?
So the second to the last, support voluntary data sharing. We know that getting the data, mining the data is very expensive, so maybe some kind of funding
For that.
to help people get the data to mine it.
Right. So we are looking at some other states who've done it. I think it could be as simple as that we are sending out requests for data sharing, and it just comes in on a voluntary basis. But I think we've talked about, like the administrative cost, like the minimum administrative cost. So we are looking at that as of now. But before we even get into that part, we just needed to know what everyone feels about, like data sharing for fluoride varnish and those sort of things. Question? Uh-huh. So, okay, so I just want to clarify that we are MDH oral health program, more like state oral health program. We consider ourselves to be dental public health. DHS or Department of Human Service is that service delivery arm, and Dr. Linda Maytan, I'm sure she's somewhere around. Dr. Linda Maytan, are you? Oh, she's there. Okay. So she has access to all the claims data. But again, these are MHCP recipients, meaning that we just all the data that I shared with you, they are only for kids who have different kinds of public assistance or Medicaid. So we don't even know what is happening with children who are on different kinds of private insurance. And for us, as state of Minnesota, we want to make sure that all our kids have good oral health, correct? So I think that's a very good question. Maybe Dr. Linda, would you like to answer that question, like as to what level of data we would need from them? I think for me, I would encourage everyone to at least submit their claims to DHS. At least that's a good way to start for kids on Medicaid. But so the question is, what kind of data would we want to opt in from them? Do you want to comment?
I wasn't supposed to speak. But I guess I'm up here. Hi, I'm Linda Maytan. I'm with DHS. And so if you guys have any questions about benefits or policy, and yes, I know reimbursement is too low, I get it. But please talk to me, okay? I've done dental public health for 18 years, so I know what it feels like. And so, yes, I'm trying to make a difference. But one of the things that Prasida and I are working on is we're part of the State Oral Health Leadership Institute with Centers for Healthcare Strategies. And we've had our first cohort meeting a few weeks ago, and we have a pretty robust proposal. One of the things that we would like to see in Minnesota is a fluoride varnish registry. There's other registries in Minnesota that are both for surveillance and also for just knowing what the landscape is. Physicians use registries all the time, so that's like a thing that they do. We've had physicians ask us when we're going to get a fluoride varnish registry, okay? Because they can apply fluoride up to 4 times a year and get it reimbursed by Medicaid. So physicians are our ally, and we want to harness that and figure out a way to just at least demonstrate that kids in Minnesota are getting fluoride varnish. We think sometimes the coding isn't done right in medical billing, so even though the CNTC visits don't look like they have a great percentage of people getting varnish, we think most kids are getting varnish, but we can't capture it, so we think if we have a registry that physicians will enter that in a registry, because they enter other stuff, immunizations and other kinds of illnesses are put in registries. But it's always voluntary. We can't force you to share information. So that's, that's part of why it's voluntary. We can require you to register with the registry. We can't require you to give your information to the registry. And the level of data is just, if Joey is in your office or in your community program or in your clinic or wherever you are, and there's a fluoride varnish application done on that day, we'd like it to be entered associated with that patient. That's it. The name tied to the procedure. Right. It's for all Minnesotans. This is our plan. It's for all Minnesotans. All registries in Minnesota are for everybody. They're not just for Medicaid. All ages. Because you wouldn't have to do any of the breakdown because it'll just be entered with the patient. So we can sort by age or by location. Yeah. Right. So we probably wouldn't, but we don't know why you wouldn't just be part of the registry.
Yes, and
Right.
I think and thank you, Dr. Linda Mitan. And I think so, because we don't, so earlier the reason why we were talking about voluntary data sharing is that other states have done it. And, you know, like this came from our Pew evaluation for our state for Sealand. So we know that amazing work has been done around Sealand. However, our ranking was B or B plus, I think, because we as MDH were asked to provide the data, and because we don't have those data on Sealand, we were not able to report those good things that was happening across the state of Minnesota. And we totally understand that when it comes to data sharing, there are confidentiality issues, there are MDH procedures and policies that we need to talk about. We need to talk about, you know, like all the insurance thing, we need to be on the same page with DHS, and there are lots of things there. But then we were not able to report, so at the end we ended up with, you know, like not a very good ranking for the state of Minnesota. So we are just trying to explore with you as to how we can better share that data, whether it would just mean all the providers would, you know, like make sure that they are at least continuing to file their claims with DHS the way they've been doing it. And all because there is still that gray area, correct? Like we have like different kinds of grants, we have different organizations providing free services. So how do we track them so that it's not only the Medicaid data that we know of, but we also know those good preventive services that we've been providing to our non-Medicaid children, because they are also children for us, right? Most of the times we do talk about underserved children, but there is a, you know, like cohort of kids who are not eligible for Medicaid, but they are still kids, right? So I think that would be and we can follow up with you after the conference, because you really brought up good points. Thank you for that. And we'll talk more about, you know, like how this can be figured out. And I was hoping Nancy would be able to facilitate the conversation between stakeholders on that. Okay. Questions, comments, success stories, or anything before we let you go? Question?
I'm with the Minnesota Fiber Rural Health Project.
Uh-huh.
And one of the things I found that would be really helpful, and it's, I don't know if it's even possible, but to have some sort of system that we know which areas are already being serviced by, say, early childhood or open door or children's protection.
Right. Uh-huh.
As a field coordinator, I go, try to strategically pick areas that
Mm-hmm.
can help, and I'll go and, talk with them and find out, they already have
Mm-hmm.
coming in, but nobody seems to, know
Right.
what everyone's doing.
Uh-huh. And I think we call it resource mapping project, and we are absolutely interested in that, because that way we know what is happening across the state of Minnesota, and we can share resources versus trying to duplicate the services. So that's definitely something that we are thinking of. It will take us a little bit of time to figure out how we can implement it, but that's definitely on our list to do. And that's a great idea. Thank you. Deb, you have something? Okay. More questions? Dr. Peterson? Dr. Peterson, you could just come over to the podium.
I have two questions. What does MDH been doing in trying to get more funding to help? Because I know that you've been helping 14 organizations, and that was really quite, I'm sorry, I had a cold, and that has been very helpful to put us together as a team. I think teamwork is so important in this case for us to be successful. And I really do see, if you read the book, From Good to Great, our pendulum is swinging in a very beautiful way, and we just need to just put more momentum to it. And so that's number one. We need more funding. And HRSA, foundations, I don't know if foundations are here. I think that even the MDH would need some funding from you who has a very heavy pocket. Please help. And the second thing is that my next question is, what will it take for us to try to get the government to pay for the oral hygiene instruction? And from the perspective that I have learned about applying fluoride is that the best fluoride is actually the low dosage. And I do still believe that the parents are the best person who deliver fluoride, and it has to be in the form of fluoride toothpaste. You get you get one shot, but you get two birds, and you get prevention of caries, and you get prevention of gum disease. And that habit should be trained as soon as teeth erupt. And that's a habit that will last a lifetime. And so please guide us. Maybe it would take lobbying to that at the medical office who have seen these children 6 to 11 times a year, that for them to be able to teach oral hygiene instruction, anticipatory guidance, and they should be reimbursed. Thank you so much. So those are the two questions.
Okay. I think there are a couple of comments that I have. When I started, I know we had limited funding. Probably it's 128 this year. It's the state funding, so I think I'm comfortable disclosing that. But for example, we are required to come up with incentive, and our focus group discussions with ethnic cohorts suggested that we should have oral hygiene kits. So we started with, I think, 1,000 kits, and then at that time, it was very hard for us to, get that support or buy-in. But now, I think we have 7,000 kits that we are already running short of, which is amazing thing, because we were able to distribute that many kits already, and in addition to that, our vendors are directly shipping these kind of kits to. These are like very simple kits. Probably one kit would cost us like less than a couple of dollars, but they really have unique EDDPI related toothbrush that is very unique to 0 to 3 population. So now the question is, where would I get all the additional funding to make sure that I wouldn't have to say no to all the amazing partners who are so eager to support us and to really distribute those kits as an incentive? Because we have known some families who've said that we cannot even afford to buy those hygiene kits, so we would really appreciate if you would give us oral hygiene kit as incentive. These are like very basic things, but they are very significant things. So I think staffing and other things, we did some restructuring so that we could accommodate 2 staff with the funding for 1 staff. So that was kind of something that MDH could have done, innovation in integration. But again, with those other things that are so critical to fulfilling the components of the bill, as Dr. Peterson said, we are very, it's been challenging. So please help us with, if you know of partners who are interested to work with us, we would love to work with them. But as I think we again go back to partners like you, Dr. Peterson, who would advocate for EDDPI and get this project to a whole new different level. Because I think that's probably the best answer I can give. And again, at the state level, I think we are trying to integrate the state project into our federal grants, so that we bring the state funding and the federal funding together so that we can have more collective impact. That's something that we can do as MDH, but in addition to that, it's very hard for us to, come up with something more sustainable. We can still write small grants or, big grants, but again, there's no guarantee that we would get it. So again, we would need to support for that.